Bismillahirrahmanirrahim. Hello and Assalamualaikum everyone. I'd like to warmly welcome everyone to the final Flex webinar episode for this year. It's truly a pleasure to have all of you join us today. University of Malaya. I'm a professor and senior consultant in anesthesiology, and I'm also ASPA Executive Committee. I'd like to introduce you to my IT support, Dr. Vivian. Dr. Vivian is a consultant, Chief of Service, Department of Anesthesiology and Perioperative Medicine, Hong Kong Children's Hospital. She is also an Honorary Clinical Associate Professor in Department of Anesthesiology, University of Hong Kong. We would like to express our heartfelt gratitude to the ASPA Education Committee for providing us with this wonderful opportunity to come together, share our experience and learn from one another. This is our itinerary for today. Our topic is holistic management of pediatric trauma, optimizing airway, blood, regional anesthesia, and post-injury rehabilitation. We hope this session will be engaging, insightful, and beneficial as we close the year with a focus on advancing knowledge and collaboration. Dear colleagues, pediatric trauma remains a leading cause of death and disability worldwide, presenting challenges unique to children's anatomy, physiology, and emotional resilience. Effective care goes beyond saving lives. It's about ensuring optimal recovery, both physically and psychologically. A holistic approach begins with securing the pediatric airway, a critical step where precision is paramount. Blood optimization follows with careful fluid and transfusion management to prevent complication. Regional anesthesia plays a pivotal role in minimizing pain and stress and not only improving immediate outcomes, but also reducing long-term psychological impact. Post-injury rehabilitation completes the journey, restoring function, addressing emotional scars, and integrating the child into the daily life. This demands a multidisciplinary collaboration across anesthesia, surgery, and rehabilitation team. So before I introduce to the first speaker, let me go through some housekeeping. So a disclaimer. Please note that the information presented in this webinar is intended for educational purpose only and is not meant to be a substitute professional medical advice, diagnosis, or treatment. The views expressed in this presentation are those of the presenter and do not necessarily reflect the opinion or policies of any institution or organization with which they are affiliated. Additionally, the information presented may not be applicable to all individual situations. For Q&A session, you can send in your question and comment via the Q&A section. Chat function is disabled. Our moderator will highlight your question to the appropriate speaker during panel discussion. Some questions will be answered by text with appropriate speaker in the Q&A section. Certificate of attendance. This will be automatically generated and forwarded to those who submitted the post-webinar survey. Post-webinar survey link will be available immediately after the webinar ends. Post-webinar follow-up email will be sent tomorrow at 17 hours Singapore time. Please ensure that you have correctly keyed in your full name and email. So I would like everyone to follow us on the Facebook, search for ASPA 2000. Please like us. And you can know more about us by visiting our website at https://aspa.2000, aspa-2000.com. And you can follow the recording of this webinar on YouTube and the previous webinar on YouTube. Search for ASPA-FLEX. Without further ado, I'd like to introduce you to our first speaker, Dr. Raihanita Zahra, a pediatric anesthesiologist from Cipto Mangunkusumo Hospital, Jakarta, Indonesia. She will talk on overcoming challenges in the airway management of pediatric trauma. Without further ado, please, Vivian, play the recording.
Hello everyone. First of all, I'd like to thank ASPA and Professor Ina for this kind invitation. I'm Nita, I'm pediatric anesthetist from Indonesia, and I'm truly honored to be here with all of you today. Today, I'll be sharing some thought and experience on overcoming the challenge in airway management for pediatric trauma cases. As we all know, managing the airway in children with trauma can be especially tricky and demands careful consideration and a tailored approach. Addressing this challenge is so important for ensuring the best outcome for our young patient, and I hope we can explore this topic together in a meaningful way. For today's presentation, I'd like to guide you through a few key points. First, we'll take a closer look at the unique anatomical and physiological aspect of the pediatric airway and why they require a more specialized approach. Then we'll talk about the classification of airway trauma in pediatric patient and core principle in airway management for this patient. We'll discuss a few specific trauma cases along with the lesson learned and backup plans as alternative airway strategy that can help us make a better clinical decision in the future. And I hope this session will be a learning experience for all of us, and I look forward to your thoughts and questions as we go along. As we know that cardiac arrest and brain death in pediatric patients are mainly caused by airway problems, as well as pediatric respiratory events carry higher mortality rate than adults. And I believe that you are already aware that anatomically and physiologically children are different from adults. Therefore, in normal condition or in congenital anomaly and specifically in trauma cases, we often encounter children with difficult airway. Note that in trauma patients, most come with full stomach. Additionally, all airway management procedures in children cannot be performed without sedation and anesthesia as they are unlikely to cooperate. That's why appropriate and timely management with establishing a pattern airway that allows adequate oxygenation from ventilation and prevent aspiration is a key priority in the management of trauma patient, and it can profoundly lead to a good outcome. Pediatric airway trauma can be categorized into three types: blunt trauma, penetrating trauma, and thermal or chemical injuries. Based on its location, it can be further divided into upper airway trauma, include airway cavity and larynx, and lower airway trauma, include trachea and bronchial tree. In children, airway trauma caused by a blunt or penetrating injury is rare, with an incidence around 1% of all trauma cases presenting to the emergency department. In blunt trauma, the former classification can be used to identify the location of the injury, and in these cases, patients often present with airway swelling, hematoma, laryngeal fracture, or associated thoracic complications such as pneumothorax and pneumomediastinum. The primary management is ensuring oxygenation using non-invasive methods and don't use back valve mask ventilation because it can lead to thoracic complications such as pneumothorax. In penetrating trauma, we can find open wounds that increase the risk of airway bleeding, tracheal disruption, and also thoracic complications similar to those seen in the blunt trauma. The focus on management in these cases is maintaining a clear airway and preventing thoracic complication. In case of thermal or chemical injuries, a sign of airway obstruction include hoarseness and stridor, and inhalational injury is not always a result from direct flame exposure to the face, but also can occur from severe burn. Airway patency may be compromised due to airway edema or sign of intoxication, so early intubation is recommended in this situation to secure the airway. Managing pediatric patients with airway trauma, in general, the main principle to remember is to assess airway patency immediately and identify signs of obstruction such as abnormal breath sounds like stridor, snorting, gurgling, and grunting, or sign of respiratory distress. Remember that hemodynamic instability and decreased consciousness can also indicate hypoxia condition and ventilation impairment. Initial management should be follow the ABCDE approach, and your management is focusing on maintaining airway patency and oxygenation, which must be performed simultaneously with the initial assessment. And a multidisciplinary approach will provide better outcomes, as is the most challenging situation. If there are any clinical suspicion in cannot intubate, cannot oxygenate, we might require a surgeon to perform surgical approach. In airway management, remember, if you fail to plan, you are planning to fail. Therefore, the raw preparation within a limited time frame along with backup plans must be part of the initial planning. For non-life-threatening situation, performing imaging such as CT scan or ultrasound can provide guidance for airway management. Let's continue to discuss some cases of airway trauma. First, this patient presented with lung trauma. In younger children, such cases are less common because the short neck provides protection as vital structure in the neck are shielded by the mandible. Additionally, children's cartilage is not yet ossified, making fractures is less likely. However, such trauma is more frequently observed in older children, often due to motor vehicle accident where the neck strikes at a hard object or in some cases due to strangulation injuries. Later in the initial assessment, patient reveals symptoms of hoarseness and stridor, and you can see the significant hematoma and bruising in the neck area, which led to airway compression. He was further complicated by pneumothorax due to exposure of the paratracheal fascia, and the patient had severe respiratory distress due to both airway obstruction and pneumothorax, and in need of immediate airway securing to optimize oxygenation. Intubation in this case should be performed using fiber optic as a guide to provide more accurate placement of the endotracheal tube while minimizing the risk of further tears or valves through intubation. Always consider about this if after intubation process the lung is not inflated or the patient becomes desaturated. Communicate with the surgeon so they always ready if front of neck access is necessary. This is penetrating trauma and is often occurring in children who run with sharp object in their mouth and subsequently fall. And in this case, you can see that the knife has penetrated the intraoral area with an entry wound in the neck. Additional complications include pain and full stomach, which exacerbate the situation, and it is impossible to pull the knife out with blind method because there are greater pain in the neck and will increase the risk of airway bleeding. Airway management via the oral route is highly unlikely because the sharp completely obstructing the airway. And first, NPA will help refill of obstruction, and you can give oxygenation through the nasal cannula waiting for intubation process. Prepare for large bore and high power suction for managing massive bleeding. And intubation should be performed via nasal intubation using bronchoscope, and be careful when you are positioning the patient because it can make a further damage. During the intubation process, oxygenation can give with modified NPA through the nostril, and you can use the other side of nostril to intubate the patient. Before administering induction agent, the surgical team must be prepared to perform FONA in case of intubation is failure. In burn injuries, airway obstruction can occur due to thermal injury, inhalation of flames or steam, and aspiration of hot liquid. Patient can present with tachypnea, dysphagia, stridor, and burns on the mouth, neck, or face, and you might also see facial or neck swelling. It is important to intubate the patient if there is a sign of a drooling, stridor, hoarseness, facial or neck burn, and increased work of breathing. To intubate this patient, ensure the tube size is appropriate and the cuff remains deflated to reduce trauma, and keep a close watch on end-tidal CO2 to monitor respiratory status, toxicity, and resuscitation adequacy. Also remember that fluid resuscitation can increase laryngeal swelling, so proceed with caution and don't extubate the patient until any airway swelling subsides. Finally, remember that carbon monoxide and cyanide toxicity are immediate concern of morbidity and mortality. This is chest wall injury. I ate this case for this presentation because although it's not directly related to the airway trauma, but airway management in this case is also very challenging. Even though the airway is not difficult, positioning the patient during the intubation process can be difficult. Additionally, oxygenation in this patient is compromised due to pneumothorax, which interfere with the ventilation process. He came to our hospital last week and he fell from the third floor and get stuck in the branch. And this case was managed by my colleague, and in this case, pre-oxygenation was provided by low flow nasal cannula, and before induction, water seal drainage was placed to prevent ventilation difficulty. Sedation was administered to ensure patient cooperation because this patient cannot lay down, and the patient was positioned in the left lateral decubitus position after he sedated. Difficult airway device are prepared in advance. Fortunately, intubation was successfully performed on the first attempt using direct laryngoscopy with double lumen tube, as the surgeon required one lung ventilation intraoperatively. This anesthesia process is carried out by two anesthesia consultants who are very experienced in difficult airway cases. So what I want to emphasize here is that in difficult cases, especially related to the airway, we must recognize our limitation, and two anesthesiologists in the room and also effective communication with the surgeon that was maintained from the beginning to completion of the surgery will produce better outcome. This algorithm can be used for airway trauma, specifically laryngotracheal trauma. We can see that for time-critical cooperative patient, OEC track or fiber optic intubation is an option. But for uncooperative patients, particularly in children, it's nearly impossible. The alternative is to perform fiber optic intubation using the rapid sequence induction or RSI technique, and mastery of both approach is essential for anesthesiologists in managing pediatric patients with airway trauma. Pre-oxygenation is an important component of RSI in pediatric patients because children can produce rapid oxygen desaturation due to higher oxygen consumption rate, easy for airway collapse, and increased risk for functional residual capacity loss. But perform pre-oxygenation in children is difficult because they limited cooperation. So consider to give premedication but avoid risk of airway and respiratory compromise. We can give midazolam. And for pre-oxygenation, we can use mask or other device such as modified NPA with high flow oxygen within 5 minutes or 8 volume capacity that can achieve approximately the same apnea time in adults. Remember that a rapid sequence induction is often performed in emergency situation where every second matters. So it is important to prepare the right equipment with proper size and consider different equipment options for backup plans. Due pressure preparation, adequate IV access is mandatory, and positioning the patient, and a team preparation discuss the roles and tasks for every team member. Prior to induction, you can consider to give a passive oxygenation prior to induction and during the intubation process with high or low flow oxygen. These have been shown to increase the safe apnea time. And you can consider to give atropine to reduce the risk of laryngospasm and reduce secretion, and premedication given to ensure patient cooperation during pre-oxygenation. Provide adequate analgesia with opioid, and medication for sedation. The option is based on hemodynamic condition. Ketamine is preferred if hemodynamic is unstable, and paralytic agents such as rocuronium is preferable in children because it's fast onset and have safety profile for pediatric patient. And don't do cricoid pressure for pediatric patient because it can increase airway obstruction. And if the intubation fail, you have to mitigate the plan how to oxygenate the patient. So consider to do surgical procedure in cannot intubate, cannot oxygenate situation. Fiber optic intubation in pediatric with airway trauma is indicated in potential difficult airway with conventional laryngoscopy, limited mouth opening, limited neck motion, or unstable cervical spine, poor laryngoscopy view due to object intraorally, or as a guide for ETT placement to avoid further damage. Possible difficulty found if there is airway bleeding, thick and copious secretion because it can make visualization very difficult, especially in small size fiber optic, which doesn't have a working channel for suctioning. The other difficulty in PETs is tough to do awake fiber optic intubation. It's for the patient with high risk RSI. So the challenge is how to perform adequate sedation with spontaneous breathing and avoid for laryngospasm and bronchospasm during the process. So you can start with nebulize the patient with lignocaine and put nasal packing vasoconstrictor. Dex and remifentanil is a favorable agent now because it can provide adequate analgesia and sedations. You can also combine it with TCI propofol. Give lignocaine 1% spray through the FOB and spray as far as you go. Remember that passive oxygenation and proper positioning will increase the success rate of fiber optic intubation in pediatric. So the conclusion for today's presentation are airway trauma in children is rare but can lead to catastrophic outcome if not managed properly. Airway trauma requires expert fiber optic intubation to avoid further damage. Proficiency in using sedation agents and rapid sequence intubation technique is critical. Effective collaboration and clear communication are vital, and a well-planned backup strategy is essential for optimal outcomes. These are the reference, and thank you very much.
Thank you, Dr. Rahanita, for the insightful lecture on different sort of trauma that can implicate the child's airway. It's amazing on how many different ways they can present to us in the emergency situation, especially with the parang at the throat. That must be very scary to see in the first place. Anyhow, we will leave the question and answer at the end. I would like to encourage all participants to put in the Q&A in our Q&A chat box, and we will look at it throughout this presentation. Next, let me introduce you to my colleague, Dr. Kevin Ng Wei Shan. Dr. Kevin is a consultant pediatric anesthesiologist in University Malaya Medical Center. He's actually a patient blood management enthusiast and has been promoting this throughout the nation. Today, he will share with us his experience and expertise in small patients, big challenges, optimizing blood management in pediatric trauma. Let us listen to Dr. Kevin.
A very good afternoon to everyone. Thank you. Thank you for having me to the ASPA team. I'm Dr. Kevin. I'm from the University of Malaya, and today I will be talking on small patients, big challenges, optimizing blood management in pediatric trauma. I have some disclosures to make. I have received research grants from Pharmacosmos and travel grants from Opta Pharma. I've spoken at events organized by both these companies. Now, this is the outline of my talk. We will be talking about hemostasis in children. Is it any different from adults? About the changes in pediatric trauma, blood management in pediatric trauma, where I have divided it into the basics, optimizing the volume and stopping the bleed. Finally, I will summarize and put it all together. So hemostasis in children, how different is it from adults? Most of the hemostatic changes are in the neonate and infant ages. Above the age of 1, hemoglobin A levels are similar to adults, and coagulation again is similar to the adults. Now, in the neonate group, HbF is predominant. As such, oxygen carrying capacity is less. Lower levels of clotting factors are present at birth, and as such, there will be prolonged conventional coagulation test or CCT. This is compensated by an increase in von Willebrand's factor and other inhibitors. there is a reduced fibrinolysis due to reduced plasminogen levels and function. As such, the newborn is slightly predisposed to bleeding. That is why we give vitamin K at birth. Subsequently, they then lean towards a more pro-thrombotic state. At 6 months, hemoglobin A is the dominant hemoglobin. Clotting approaches adult levels, which finally becomes adult levels at 1 year of age. Now, trauma. We've all heard about the lethal triad, which is hypothermia, acidosis, and coagulopathy. It's now been called the diamond of death with the addition of hypocalcemia to this triad. Now, this is very important. Now, after an injury, there is both the adaptive and maladaptive responses. Of course, you will be activation of the clotting cascade, and you will have all the tissue factors and all the other substances all activated, and a clot forms to stop the bleeding. Now, in massive bleed or hyperperfusion, what happens, there is disruption to the glycocalyx further. There is leakage out of the endothelium where the intravascular contents leaks into the interstitial tissue. As such, then it develops microvascular and macrovascular thrombosis and inflammation. Now, this is the maladaptive response. So in children, something interesting happens. Now, this is a research by Nake et al., where they did a time course of coagulation and fibrinolytic parameters in pediatric traumatic brain. And what they found is all the CCTs were prolonged in children as compared to adults at admission and up to 3 hours after the trauma. And one of the most clear things that was seen was a real drop in the fibrinogen levels and was significantly lower than the adult levels in children from admission 3 hours and 6 hours after the trauma. So this does show that children tend to have lower levels of fibrinogen and are more predisposed towards coagulopathy after an initial insult. So what happens in trauma? After trauma, there's tissue injury leading to bleeding. And from the bleeding, we then develop coagulation factor loss. There is consumption of clotting factors. This is dependent on the extent of injury. The endotheliopathy then leads to neurohumoral activation. The inflammatory response is activated, cytokine release occurs, the glycocalyx is disrupted, so the coagulation becomes dysregulated, and there is hyperfibrinolysis from tissue plasminogen release. Our resuscitation itself does cause dilution of coagulation factors due to overzealous fluid resuscitation. There's acidosis and hypothermia from our own fluids. All of this then leads towards something called trauma-induced coagulopathy. So what can we do? I'm basing a lot of my slides from these management recommendations from the Pediatric Traumatic Hemorrhagic Shock Consensus by Russell et al. From 2023. So patient blood management in trauma, I divided it into basics, optimizing volume, and stopping the bleed. Right, so in basics, we are looking at temperature, pH, the use of tourniquets, and tranexamic acid in children. We will then talk about how to optimize volume, and finally, to stop the bleed, either surgical interventions or correcting the coagulopathy. So for the basics, acidosis, coagulation is enzyme-driven, as we well know. Acidosis will lead to a decrease in thrombin generation and an increase in fibrinogen breakdown by 50% for thrombin generation and 30% for fibrinogen breakdown for every pH decrease of 0.1. For temperature, a decrease of temperature of 1 degree Celsius increases the incidence of transfusion by 22% and increases the blood loss by 14%. The consensus statement mentioned that in exsanguinating extremity hemorrhage, they recommend the use of tourniquets, by individuals with training. This is because if you used indiscriminately, it can lead to worse outcomes. The rationale behind the use of tourniquets is that it reduces the crystalloid administration, reduces transfusion requirements, and there has a small survival advantage for patients treated with tourniquets, particularly when applied before the onset of shock. Tranexamic acid. Now, the CRASH-2 trial has provided quite a strong evidence for tranexamic acid use in adults, and this is where the 3.1 statement comes about, where it is recommended that the empiric use of tranexamic acid be given within 3 hours of injury. CRASH-2 did show some very good results for adults, but in children, this evidence has yet to be replicated or substantiated. Al-Jabori in 2021 did a meta-analysis of available trials, and there were very few, and it showed no difference in survival for tranexamic acid or no tranexamic acid use. However, in patients where the viscoelastic testing shows hyperfibrinolysis, tranexamic acid would be indicated. Now let's talk about optimizing volume. What are the methods that we can do to optimize volume? We have to look at fluid type, ratios, and of course, the use of massive transfusion protocols. Now, we should transfuse blood early. Most recommendations have shifted from crystalloid heavy or transfusions or resuscitation towards blood transfusions. We should choose blood over crystalloids where available. We should use, if available, low titer or whole blood is preferable to 1:1:1. Now, low titer or whole blood is probably not available widely. We'll discuss that in a little while. As such, we should aim for high plasma or platelet to RBC ratios, aiming for more than 1:1. And we should resuscitate to permissive hypotension levels in patients without TBI. Now, in MTP. Now, MTP is quite widely accepted for adults. It's less established in children. The ratios are still yet to be established. And just to remind all of us, massive transfusion, the definition is more than 40 mL per kilo in 24 hours loss. Now, the consensus statement, what it mentions is that we should prioritize the use of blood products. We should use low titer group O whole blood, high plasma to RBC, and high platelet to RBC ratios. So what should we do? This is the dosing components for massive transfusion. Most of the time, my ratios are 20-20-10 for FFP, RBC to platelets. Cryo as required, usually about 10 mL per kg is needed, but they do not recommend empiric cryo at this current moment. I use Rotem to guide my cryo administration or fibrinogen levels, whichever that is available. After 40 mL per kg transfusion of this massive transfusion protocol, we should consider factor concentrates if volume is sufficient. This is because we would like to become more targeted and less indiscriminate when we come to correction. So low titer O whole blood is defined as co-stored RHD positive or negative whole blood with low titers of NTA and NTB ranging from 5 to 250, and most of the studies have used less than 200 as their cutoff. What is the benefit versus component therapy? We have faster resolution of shock, lower volumes of transfused blood products, and an independent association with increased survival in massively transfused patients. And you can see here, right, the volume that is given is of course less. You get better hematocrits, higher platelet levels, and more active coagulation factors as compared to the component therapy. This is because, of course, there's less storage lesions in whole blood, but it's definitely does not store as long. Now, the problems with this, of course, is accessibility to this low titer or whole blood. And this is something that should be discussed with your blood banks. If you are seeing a lot of trauma patients, a lot of severe trauma patients, this is something that you can consider. If you look at it, the amount of anticoagulants and additives present in whole blood is less than compared to the various products. So permissive hypotension is something that we do consider, especially in adults, but let's go back to what we know about children. Now, children tend to have large reserves, large physiological reserves, but once they overwhelm, they bungee jump. And that's what I call the crash after they have compensated. As such, their blood pressure will tend to maintain fairly well, and they will have tachycardia as their only sign, followed by a sudden drop in blood pressure that is usually very refractory to most of our treatment. So we have to catch them before they jump. Now, hypertension on presentation is associated with 13 times higher mortality. There is no high quality evidence for permissive hypotension in pediatrics, but of course, the final aim is to aim for adequate organ perfusion to brain, kidneys, liver, and tissues. And how do we do that? We measure lactates, urine output, and even liver function tests. So what are our targets as per the ATLS and Kim et al. From 2019? If there's no traumatic brain injury, we can target low normal systolic blood pressure or MAPs based on the age and height and weight related BP charts. So I would aim normally about 5th to 10th centile, no need for aiming 50th centile and above. In traumatic brain injury, you would aim a CPP of more than 50 mmHg. So if we take an ICP of 20, you will be looking at a MAP of 70 or more. So how do we stop the bleed? We should consider damage control surgery. From the 6 Euro guidelines on trauma, we recommend damage control surgery in the severely injured patient presenting with hemorrhagic shock, signs of ongoing bleeding, coagulopathy, combined abdominal vascular and pancreatic injuries. Other factors that should trigger a damage control approach are hypothermia, acidosis, inaccessible major anatomic injury, a need for time-consuming procedures. If none of this is present, they recommend primary definitive surgical management. Now, in pediatrics, this is fairly similar. We would discuss with the surgeons which would be the best approach. Remember, hypotension is a late sign, so we may not see the shock, but we will see the tachycardia. The key takeaways would be to do a fast scan, early CT scan, and remember the large physiological reserve. So how do we stop the bleed? Targeted approach is advised. I would use viscoelastic testing over the conventionals. VET guides in children is less well established, but like I mentioned earlier, above a year old, most of the coagulation is fairly similar to adults. So we are using adult parameters and adult pathways. This is an area of future research that can be looked at. Product concentrates in adults is widely established, used extensively in Europe, where they have done away with most of the products, the blood products, the fractions, and gone almost fully to product concentrates. In children, the 2023 consensus statement says there is insufficient evidence to recommend the use of PCC and fibrinogen concentrate. My take on this, targeted resuscitation is still the key. And as such, VT guidance is what we should be doing. And if available, fibrinogen concentrate is safer than PCC. So let's put all of this together. So general assessment and investigations. On scene, we have to train our first responders to use blood and product resuscitation as indicated. We should use and apply tourniquets if indicated, and it should be applied properly by trained professionals. In the ED, we should do a quick primary survey and imaging with FAST or eFAST. We should do the conventional testing plus fibrinogen, and if available, do a viscoelastic test. Blood resuscitation should be started early. There should be targeted hemodynamics. We'll discuss this in a short while. And of course, consider damage control surgery and ICU for stabilization if damage control surgery is not indicated. So how would we resusc? The initial resuscitation, ATLS recommends 20 mL per kg of crystalloids. As such, it should be used sparingly before switching to blood. Once blood is available, we should switch over and activate MTP if there is massive bleeding at this ratio 20-20-10. What are the targeted corrections with VET? Fibrinogens should be aimed more than 1.5 gram per liter, or if you're looking at the ROTEM, we are looking at the FIB-10A5 of more than 10. Anything in the double digits is good. We should give tranexamic acid within 3 hours as per crash, and it should be dosed at 15 milligram per kilo. What are the targets? We've mentioned normal temperature, normal pH, BP pressures, the BP targets as above, and we should aim the MEP targets as per our patient. So we have to look at our standardized BP chart and then determine what is best. There is no one number that is best for all patients because, as we know, children differ across the ages. Now, we should measure lactate, urine output, and after all the transfusion, measure your calcium levels, your activated calcium levels, and correct after every transfusion. Special populations, I like to talk about traumatic brain injury and non-accidental injuries. Traumatic brain injuries, we've mentioned CPP target more than 50 mmHg. And what is interesting is the unique trauma-induced coagulopathy that occurs. This is likely due to the release of active substances from the disrupted blood-brain barrier. As such, the coagulopathy is worse for degree of injury. So even though minor injuries tend to have worse coagulation profiles, which further worsens the traumatic brain injury. In non-accidental injury, a lot of times the presentation may be a bit delayed. There's a high incidence of associated hypoxic brain injury, but the TIC was very similar to traumatic brain injury, and when TIC was present, it is the strongest predictor of mortality, increasing the odds of death by 3.65 times. Finally, when all is stable, do not forget to replete the iron stores, either with oral or IV iron supplementation. IDA is present in about 30 to 50% of our pediatric population. Vitamin D deficiency is always a concern. We tend not to have much sun exposure nowadays for our children. They're all kept inside. But this is something that we need to consider to optimize the patient so that we do not send our patients home on an empty tank. If you send them home on an empty tank, they will suffer from fatigue, growth restriction, impact cognitive development, and behavioral changes. So do remember to replete the iron stores at the end. Thank you very much. I'm open for questions in the Q&A, and this is my email. You can always contact me if you'd like more information. These are my resources. I'm happy to share with you the various articles that I've already collected. So please reach out, and thank you again, ASPA, for having me.
Thank you, Dr. Kevin Ng Wishan, for that in-depth lecture on short but in-depth lecture on patient blood management in patient pediatric patient in trauma. It's interesting that that you reminded us that we need to, apart from optimize all the blood and blood product that we use, we need to look at all the other factors such as preventing hypothermia, acidosis, and ensuring that our electrolytes in the children are normal. So for the next talk, I would like to welcome Dr. Anju Gupta, who is an associate professor in anesthesiology, critical care, and pain medicine in All India Institute of Medical Sciences, Delhi, India. It's interesting that Anju is recognized as Top Woman Leader Innovator of 2023. Congratulations, Anju. And without further ado, I'd like to welcome her to deliver her talk on role of regional anesthesia in managing pediatric trauma. Thank you.
Very good evening, everyone. Today, I'll be speaking on the role of regional anesthesia in pediatric trauma. I bring greetings from my institute, All India Institute of Medical Sciences, Delhi, India. A bit about my institute. It is a tertiary care apex institute, currently catering to a patient load of around 15,000 per day, and it has 9 specialty centers. So the roadmap to my presentation would be a brief discussion on a pediatric case scenario, some unique considerations for pediatric trauma, some differences in children with respect to regional anesthesia, so role of regional anesthesia in trauma, various controversies associated with trauma. I have nothing to disclose. Coming to the case presentation, this is a 6-year-old boy who falls from the bicycle and strikes the handlebar and complains of right elbow pain and right upper quadrant pain, lands directly on the ground with a flexed arm. There is no head injury, no other significant injury, and examination reveals a FLEX score of 7/10, and there is abdomen is tender. X-ray reveals a displaced supracondylar fracture, and abdomen reveals a tear of the liver. Now, what are the differences between the pediatric and adult trauma scenarios? Trauma is a leading cause of death in children and young adults. And drowning and death from fire and burns are much more prevalent in the children pediatric age group. Apart from the usual mechanisms of trauma, child abuse is a common cause of injury, especially in infants. The head is larger in size, leading to a higher incidence of traumatic brain injury. There is a less fat and connective tissue, and organs are in closer proximity. So there is a higher incidence of multiple organ injury. Skeleton is much more flexible, so the blunt thoracic trauma may lead to pulmonary contusion despite an absent overlying fracture. Now, physiological and anatomical differences in children and adults. The nerves, vessels, and tendons are very small and superficial with less adipose tissue, and they lie very close together. So there is a potential risk to nerve and structures around the nerves. Hence, the importance of ultrasound is much more in this age group for precise location of the structures. The endoneurium has a loose connective tissue. Nerves have a shorter diameter with incomplete myelination. And therefore, there is an early onset of sensory and motor blockade with even lower concentration of the local anesthetic. So coming to the physiological changes, these children have a higher cardiac output. So there is an increased systemic absorption of the local anesthetic, and there is a higher proportion of active sodium channels, so leading to a high affinity to local anesthetic, and hepatic metabolism is immature. These all factors lead to a risk of cardiac toxicity. Also, there is a reduced concentration of alpha-1 acid glycoprotein. So there is a risk of accumulation with prolonged infusion. So as I've already mentioned, that there is an increased risk of toxicity with local anesthetics in this age group. There is a more need for staying within the maximal dosing guidelines. Now, trauma patient may present without, you may not know the exact weight and height of the child who presents to emergency department. So what we can do is use the Broselow's tape for knowing the weight and other parameters. And we have to stay within the maximal dosing guidelines. We should use long-acting local anesthetic, but preferably levobubican, ropivacaine, which have a better toxicity profile. The saving grace is that there is a decreased minimal anesthetic concentration required for blocking the impulse conduction. Hence, we can even get a surgical blockade with lower concentration of local anesthetic. Now, various adjuvants are preferred by various anesthesiologists, like dexamethasone, dexmedetomidine, clonidine. However, my personal favorite is clonidine, which provided up to 2 to 4 hours of prolonged anesthesia as compared to bupivacaine alone in this trial, which we conducted in pediatric patients for upper limb trauma. Now, the most important aspect of pediatric pain management is doing a good pain assessment. So we should familiarize ourselves with a tool and use it repeatedly for getting adept at using the tool. And we should know what tool to use in various age groups. Like pre-verbal children, we generally use FLEX score, which is very easy score to use. Then children 3 years or more are amenable to self-reporting tool like cartoon faces. Then more than 5 years, we can use the standard VAS score, and more than 8, we can use the verbal rating scale. So self-reporting tool is always the gold standard and should be used whenever possible. The specific tool for trauma is Elder-Hay Triad Pain Score. So these are the various self-reporting tools. Now, coming to the role of regional anesthesia in trauma, up to 77% patients with musculoskeletal injury may develop chronic post-traumatic pain, and a good acute pain management will go a long way in preventing a chronic pain after the trauma. 60% of multiple trauma patients with severe injury always have an associated extremity injury. Hence, regional anesthesia is very well suited for analgesia in trauma patients. The advantages of regional anesthesia are obvious. It leads to a better improvement in the wound healing because of a decrease in catecholamine release and stress response, and better flow to the local area by a sympathetic blockade. And it leads to, in turn, to a decrease in the opioid use, and thereby improving the recovery profile of the child and leading to a faster recovery. And then the impact of regional anesthesia on other outcome is under research, like the role in prevention of delirium and chronic post-traumatic pain and post-traumatic stress disorder, which are very, very prevalent after trauma. Now, there are various barriers to use of regional anesthesia in pediatric trauma patients, like the various contraindications in regional and in trauma patients, like distorted local anatomy, coagulopathy, acute compartment syndrome, risk of compartment syndrome. So all these things will lead to a hindrance in application of the trauma, especially by the surgeons. They will generally not allow in such cases. They may not allow. So then there can be competition with the ongoing resuscitation objectives, and analgesia is generally given a lower priority in such a scenario. There may be inadequate equipment and training in ED. There may be a lack of knowledge of pediatric drug metabolism and pharmacokinetics. Then staffing requirements are more if we are performing such procedures to monitor the patient, and it may interfere with the ongoing neurological assessment. And always there is a fear of complication in this population. Then though there are hindrances, but we should be aware that there are various harmful effects of untreated pain, especially in pediatric patient. The hemodynamic effects include tachycardia, hypertension, then a very increase in oxygen consumption too many times. And in trauma patient, there is already a high oxygen consumption, and pediatric patient already have a double the oxygen consumption of adults. And a further increase in oxygen consumption can lead to increase hypoxia and lactic acidosis. Also, the hormonal and metabolic changes can lead to further increase in lactic acidosis, which will worsen the acidosis of trauma. And then this will worsen the lethal triad associated with trauma. So untreated pain in infant in older children can lead to infant can later on lead to impaired social and cognitive skills and various other self-destructive behaviors. So it is very, very paramount that we treat the acute pain well. In trauma, in pediatric patient, the application of regional anesthesia may start from pre-hospital scenario, where it can be required for extrication and pain management. Then on arrival blocks can be used, then perioperative analgesia for various procedural analgesia. It can be used. It can be used as a primary anesthetic when when GA is very high risk. Then it can be used as a supplement for perioperative analgesia. It can also be used for chronic pain management and rehabilitation. Regional anesthesia, as you can see this gruesome picture of a child who has sustained a trauma of the bilateral foot crush injury, and the child received caudal analgesia with general anesthesia for surgery. Immediately on arrival, he was shifted to the OT, and as you can see that the child is very, very comfortable, and the flag score appears to be 0 at this time, post-operatively. So now you can ask me, what are the various regional anesthesia techniques which can be applied to children? So there is no regional anesthesia technique which I am aware of which can be applied for adults, and which is not, which is contraindicated in this age group. Any kind of block which you can think from head to toe is applicable to children also. And even now with the use of ultrasound, we have gone to even superficial sensory nerves to the level of sensory nerves also. We can precisely locate and block even the superficial sensory nerves. So from head to toe, every area is amenable to the blocks. Now, some general considerations. The dose of local anesthetic, we need to be aware of the dose, precise dose. For upper extremity procedure, as a general rule, you can go up to 0.5 to 1.5 mg per kg. For lower extremity, we can go up to the dose of 0.5 to 1.5 mg per kg. For facial plane blocks, we can go up to the dose of 0.25 to 0.75 mg per kg. In terms of ml per kg, generally the dose used is 0.1 to 0.3 ml per kg for most of the blocks. Now, preventing systemic toxicity is very, very important, and this is the most dreaded aspect of regional anesthesia. We should always go for a lesser toxic dose drug like levobuprofen, ropivacaine, which have a more cardio-stable profile. We should not exceed the maximum dose. We should always calculate the maximum dose, and even for neonate, we should go half of the maximum dose. Now, we should inject in very small aliquots and always aspirate repeatedly. Always use ultrasound wherever it is available. Repeated doses and infusion should be limited in neonates to maximum up to 2 days. And epinephrine containing test dose should always be used. Then all children given any local anesthetic and especially those with continuous infusion should be continuously monitored. And regional anesthesia should only be used in area with resuscitative equipment and intralipid where it is available. Intralipid 20% emulsion should always be stocked in every area where regional anesthesia is performed. And coming to the dose of intralipid, for pediatric doses 1.5 to 2 ml per kg, and infusion can be used in the dose of 0.25 ml per kg per minute to a maximum dose of around 12 ml per kg. And adrenaline should be used in a lower dose of 1 microgram, less than 1 microgram per kg. Appropriate equipment is very, very important. We should have the smaller size needles, that is 1 to 2 inch of insulated nerve block needle. If we want to go for continuous block, we should have a 19 gauge and 50 mm 2E needle, which will be better. Then we should have a small footprint block like a hockey stick probe. So all these things are important. Another key thing to plan pediatric regional anesthesia is a good communication. Maintaining a good communication with surgeon, patients, and your team is very, very important for success of the blocks. We should inform the surgeon that we are planning a block, and we should discuss the possibility of impairment of sensory motor blockade after the block, after the institution of the block. Then informed consent and documentation is very, very important. We should inform the parents and the child about the possibility of some common adverse effects, and even a mild complication like a Horner syndrome can be very distressing to the child. Like in this case, I got a midnight call from the parents. He was given infraclavicular block for upper extremity surgery, and then he developed a Horner syndrome in middle of the night after continuous infusion, and just a bit of counseling was successful. Now you can ask me, how will we choose a block for a particular surgery? Now we have plethora of blocks for possible for even for every surgery. We have a plethora of blocks which are possible. So how to go for a block? We should choose a block which is effective, but it is the most distal and most site specific. So that will limit the dose which is required for that particular block. So we should consider various anatomical aspects. We should consider various limitation, contraindications, need for analgesia or surgical anesthesia. All these things should be considered, and then the block should be selected. But the crux is that we should go for the most distal. So this is the child who had sustained a crush injury to the middle finger, distal middle finger. And what I planned was I gave him after general anesthesia and LMA insertion, I gave him a selective median and radial nerve block. And this is the postoperative phase. He is being asked whether he has a pain, and he is denying having any pain. So now whether we should use single shot or continuous block. In trauma patient, generally they have a very intense pain, and it can be long standing pain. So even infusions have been continued for weeks. So catheter should always be considered, and continuous blocks are always better. Also, these patients may keep on coming for some debridement, some minor dressing, that kind of procedures. So it is better to go for a continuous block. Infusion, however, should be limited in dose and duration in infant who are less than 3 months. And also, many children find motor blockade very unpleasant, and we should go for lower concentration. So now this literature is coming up for continuous infusion. We should be flexible in using various blocks. If there is a multiple incision sites, then we should customize the block as per the individual case. We should calculate the total permissible dose and divide it into the type of blocks planned. We can even space out the block, give one given at the beginning and one given at the end. And we can dilute the permissible local anesthetic to the required volume. Now, ESP is a very, very promising block, because it is possible to give this block from cervical spine till the sacrum, and we can cover even the lower extremity as well as the upper extremity and whole of the trunk. So it is a very, very promising thing, especially for a scenario like trauma where multi-site multi-trauma is polytrauma is very common. So it can cover a widespread dermatomal area. So now new kid on the block is recently sacral ESP has been used for various perineal, and I gave this block for the lower unilateral lower limb trauma in 2 cases where it was very effective and no opioid was required till the follow-up period. It can also be an option in children who have contraindication to caudal anesthesia. Now, regional anesthesia has another application for children who have complicated cases or trauma, like in this child who had a multiple drug allergy, anaphylaxis, and in this another report where there was acute hepatitis. And this Zadrezil et al., they described 565 cases of use of brachial plexus block with mild sedation, and it had a 95% success rate. So it can be used to avoid GA whenever it is needed. This is my experience of awake pediatric anesthesia, regional anesthesia in various cases wherever the risk of general anesthesia was very high, and it helped us sail through. Now, whenever you have to, you want to give awake regional anesthesia to a child, you have to make friends with the technology and use this to your advantage, like smartphone and various video games. Now, there are some controversies which are associated with regional anesthesia and trauma. People say that it is detrimental. It can be, risky to perform the blocks in asleep patients, like pediatric patient who will always need some sedation or general anesthesia. However, several prospective registries have negated this fact, and they have found very low incidence of regional anesthesia complication under general anesthesia. And ISRA and ASRA joint guidelines have emphasized the fact that pediatric regional anesthesia should be performed under deep sedation general anesthesia, which is a standard of care. Now, one very important controversy associated with extremity traumas is risk of compartment syndrome. That is why it is very underutilized in compartment syndrome in extremity trauma. The concern being that dense analgesia by any form of analgesia like PCA, peripheral nerve block, it can mask the early sign of a developing compartment syndrome. So safety in this of regional anesthesia, it has been seen that very dilute concentration, which will not compromise the neurological examination, can be used, and ischemic pathways, they travel by a different pathway, and peripheral nerve block may in fact permit the early detection of acute compartment syndrome in territories of the unblocked nerve. So large trauma centers have incorporated acute pain services in their who have expertise in peripheral nerve block and trauma. Now, there are no published cases of regional anesthesia delaying the diagnosis of acute compartment syndrome. In contrast, several reports of pain breaking through the block has facilitated the early diagnosis of developing compartment syndrome. In pediatric literature, this large registry, they reported that there was 12 cases which were identified. None of them were masked by the epidural analgesia, and pain out of keeping with the clinical expectation was a common feature in all. So there are various safety measures which can be applied to prevent to detect the acute compartment syndrome early, even while we use regional anesthesia, and all these should be incorporated in your routine practice. Especially with continuous infusion, we should go for a lower dose, which will avoid any motor block. Now, pre-existing nerve injury, there is a phenomenon of double crush syndrome, where patients with pre-existing nerve lesions are more susceptible to further injury when exposed to a secondary visit. So, though it is controversial, but we can individualize the risk-benefit ratio, and less potent local anesthetic and reducing the volume concentration, it is very much possible to do this block by after adequate documentation. Anticoagulation, because trauma, the patients are susceptible to coagulopathies. So various regional anesthesia guidelines should be followed in such patients, and safety measures should be adopted, and peripheral nerve blocks are safer. Now, limitation of regional anesthesia in trauma, there can be regional anesthesia may not be appropriate in various scenarios, which I have already discussed previously. Now, coming back to the case management, which I initially mentioned, the supracondylar fracture was repaired under general anesthesia with supraclavicular block, and postoperatively continuous infusion was given. So supraclavicular block, one important consideration is pneumothorax. So we should always maintain the pleura in view to reduce the risk of pneumothorax. And in young children, we should use smaller probe with a smaller linear transducer, which will better fit in the supraclavicular area. We should use smaller needles. Out of plane approach may be dangerous, and we should use a shallow needle path. So anatomical anomalies should be ruled out, especially vascular anomalies, by using Doppler. And we should always watch the needle end till needle end to avoid any complication of intravascular injection, intraneural injection, and pneumothorax. Now, the importance of compassion and care, compassion in pediatric regional anesthesia cannot be overemphasized. These pediatric patients, compassionate hand holding even can go a long way in giving a good comfort to the child and a satisfactory analgesia. So to sum up, these patients with acute trauma frequently require complex management and have competing priorities, but literature has highlighted the safety and benefit of regional anesthesia. And in addition to improving the patient comfort, regional anesthesia significantly reduces the opioid requirement, and compartment syndrome is rare and can be detected easily even with regional anesthesia. But strict vigilance for local anesthetic toxicity is a must, and there is a need for research towards outlining the best analgesia protocol. Thank you very much for your patient listening. I am happy to announce the launch of our new second edition of our Barash Clinical Anesthesia textbook, which is recently launched.
Thank you, Dr. Anju, for the detailed lecture on the on regional anesthesia in children with trauma. It is important to treat the acute pain with appropriate manner, and regional anesthesia, I believe, has a major role in this. Thank you once again, and congratulations on your book. So, dear colleagues, we have reached to our last lecture. I believe all our treatment that has been mentioned above from our different anesthesiologists at the end of the day is to allow the children to recover and to allow them to reintegrate back to their normal life the soonest. So today, we are privileged to have Dr. Mazlina Mazlan, a professor in rehabilitation medicine, a Faculty of Medicine, University Malaya, to share with us her expertise on rehabilitation, post-traumatic injury, essential strategies for optimizing pediatric recovery. Without further ado, let's listen to her lecture. Thank you.
A very good afternoon. I am a rehab physician, and I thank you very much to the organizers for allowing me to be part of this ASPA-FLEX webinar series. So today I am going to discuss briefly about the essential strategies to optimize pediatric recovery after post-traumatic injury. The global prevalence of unintentional pediatric injuries was nearly 8.5 million, and children comprise of 25% of all these trauma patients. Not surprisingly, the Southeast Asia and the Western Pacific countries accounted for the highest number of pediatric trauma-related mortality worldwide. And as for the survivors of the pediatric trauma, there are multiple factors influencing the final functional recovery. So if you look at this slide, we can briefly divide the factors generally to the age of the patients, the patient factors, age, development, and accordingly to what their needs. And the other factor is injury characteristics, the type and severity of the trauma that occurred to them, the concomitant injuries that occur together, the complications of those injuries, the surgical and medical care, which include the acute, pre-hospital, subacute, and long-term management of these medical complications, family and psychosocial support. Last but not least is the rehabilitation interventions, and I think this is a very important factor, which comprise of the access of the rehabilitation itself, the timing of the rehabilitation interventions provided, and the dose of the rehabilitation interventions, which is the frequency, intensity, and the type of the rehabilitation interventions itself. So most of us who are not familiar with rehabilitation often equates rehab with physiotherapy only, but rehabilitation itself has some more comprehensive definition, way beyond just the therapy or physiotherapy alone. So WHO, the World Health Organization, has defined rehabilitation as a set of interventions designed to optimize function and reduce disability. So this intervention, or this set of interventions, is actually a combined and coordinated intervention using the medical measures, social, educational, vocational measures, as long as we can train or retrain an individual to the highest possible function and they can go back to the previous function. So what is this medical measures? So the medical measures are using either pharmacology, invasive or non-invasive, clinical procedures, medical technologies, and also the conventional therapies that we know of, such as the physiotherapy, occupational therapy, speech therapy, psychotherapy, and so on and so forth. Because the interventions mentioned by WHO is comprehensive, the team providing the rehab program is also comprehensive. This is an example of a few teams available in University Malaya Medical Center. If you see the top picture, that is the main multidisciplinary team, which is the pediatric rehabilitation team, comprised of the rehab doctors, nurses, and all the therapists, supported by the other relevant teams, for example, the P&O technicians, the rehab technology wheelchair technologist, child psychiatrist, psychotherapist, and the other picture is the neuro rehabilitation team, which support the main pediatric team if the pediatric trauma involving the central nervous system, such as the traumatic brain injury or spinal cord injury. We are also in the middle of creating another important multidisciplinary team, which is the critical care rehabilitation team. We already have a few clinicians involved, but we want to make it formalized, hopefully by next year, to also support the rehab intervention from the ICU itself. This is the normal rehabilitation pathway and the normal place of care from the acute phase of injury until the social reintegration phase. However, in pediatric population, depending on the age of the patient, some rehab interventions are not provided strictly in the hospital because the parents may prefer to provide the interventions or strategies at home with an outpatient setting. This slide just shows the facilities that we have in University Malaya Medical Center. We usually provide the inpatient rehabilitation of 2 to 3 hours a day, 5 days a week during the weekdays. Now we go to the strategies that can promote functional recovery after pediatric trauma. So number one, it is early referral for rehabilitation intervention. There are higher evidence of better functional outcome if the patients are referred early to the rehabilitation team. The aim is always for a continuous chain of care from the intensive care discharge to inpatient rehabilitation admission. This is because it is to allow the rehabilitation team to conduct a comprehensive impairment and functional evaluations regularly to guide us to determine our rehab goals from time to time. So there are, in the literature, have shown that there are adverse effect and diminished completeness of functional recovery and also diminished extent of functional recovery if there is a delay of rehabilitation admission after medical stability from the intensive care. So I think the highlight here is that there should not be a break between intensive care and inpatient rehabilitation in suitable patients, and it should be included as the trauma continuum care for the children after pediatric trauma. Second strategy is to achieve effective pain control. Pain will not get us to start rehabilitation program. And in fact, pain management is one of our rehab goals, and an important rehab goal, especially in children post-trauma. So there must always be a high index of suspicion. And for us, it has to be a proactive pain management, and we do not need to wait for the patient to report about pain. We cannot rely solely on the self-report or the overt signs because the patients, or depending on the age of the children, they may not be able to tell us that they're in pain and probably just crying all the time. And we need to do regular assessments throughout the care. And another important factor about effective pain management or pain control is that we want to aim to reduce anxiety and distress, because heightened anxiety and heightened distress will directly affect the pain severity as well. This will include procedural pain associated anxiety, and also the environmental factors, which is if the family is showing a very high distress and anxiety level, this can also somehow indirectly influence the children's pain severity. We also need to use adequate medications to control the pain, and another factor is to use a lot of distractions during our rehab program and intervention. Either we use music, play, games, or allow them to watch movies, reading a book, or allow them to use their own plushies or toys that they have, and virtual reality. These are some of the distraction methods that have been used in the past and in the literature to allow us to provide the optimal rehab care in association with effective pain control. At the moment, there is no single guideline that we use to manage pain in pediatric patients post-trauma, apart from the strategies that I mentioned in the slide earlier. This is 3P, which is an evidence-based approaches to pain management for minor procedures performed on the patients, because pediatric patients post-trauma are more, highly likely to have multiple procedures done on them. So using this 3P, which is using physical strategies, psychological strategies, pharmacological strategies, is one that we try to use, which include while providing rehab interventions to them, because rehabilitation interventions, for example, moving them, moving the limbs, mobility and all the rest, will also cause pain, and we use this concept together, the 3P concept. I would like to share a case of this 6-year-old boy who has a post-traumatic amputation day 8, referred to as he had a below-knee amputation post-trauma. He kept crying and kept saying sakit, which is pain, but could not explain when asked further. He just refused to let anyone touch the stump or the leg. Even putting on the pants is a difficult task, because he would just cry and cried and cried. And when we examined the stump, there is no infection. The surgical wound was actually healing quite well. He was already on the maximum dose of paracetamol and syrup morphine. So we could not proceed with therapy. We could not, properly examine the stump or put a stump bandage. And there is a high suspicion of neuropathic pain here. We kind of suspect that he may have allodynia or phantom limb pain as well, because 30 to 80% of pediatric trauma post-amputation may have this phantom limb pain within the first 1 month, or it can happen after the second or third week of amputation. So we started gabapentin on him, and immediately the pain actually resolved within the next day. We now able to taper down the paracetamol, the morphine, and finally took off the medications. He was added TENS to the contralateral limb as an adjunct measure to manage the pain, and the pain actually resolved. That is because of the high suspicion of neuropathic pain. In the literature has already shown that primary triggers of phantom pain post-traumatic amputee in children include exercise of the limbs, objects approaching the stump, cold weather, or even feeling anxious or nervous. And this is one of the cases that we want to highlight, that we have to have a very high suspicion and suspect and treat according to what we feel the diagnosis is. Strategy number 3, early mobilization. Because immobility alone has been shown to affect multiple body functions, and the adverse effects can be seen on various systems such as the musculoskeletal, skin, respiratory, CVS, hematology, metabolic, neuro, renal, and even GI system. Therefore, developing a safe early mobility program for post-trauma patients is extremely important, even in children. This is just to ensure that they do not have the secondary complications of prolonged immobility, which I've listed here. The mobility goals should be appropriate to the patient's age, to the patient's premorbid function, strength, endurance, and the current medical progress. So there is this suggestion that immobility is the main modifiable factor in PICS ICU contributing to functional disability, and this disability or these harms caused from the prolonged immobility can persist up to 1 year post-discharge from the pediatric ICU, and this highlight the important aspect of early mobilization in our rehabilitation program. There are a few guidelines available to ensure safety for early mobilization in pediatric ICU. So this is an example of a traffic light system from Australia, which uses 4 different types of animals, the native animals, to showcase or to guide the clinicians of the level of mobility for the pediatric patients. There's lizard, there is also koala, there's wombat, and there's kangaroo. So although we don't have one structured guideline for pediatric population, the early mobilization in Malaysia yet, we hope to have it soon. We base our practice using the existing guidelines available in the literature, such as this traffic light system from Australia. Some pictures showing the different level of mobilization, early mobilization in the ICU. Although towards the left, the kangaroo, that's taken from Johns Hopkins Children's Center, and you can see the doctor that's racing together with the patient. This is definitely level kangaroo with all the wires actually still attached to all the tubes, and the tubings is still inside too. Most of us are worried about the safety of early mobilization in pediatric ICU. This paper found that from the 4,658 mobility sessions on 82 children in PICS ICU in the US, the rate of safety event is only 4%, with majority of them being transient. For example, just a simple, just a small blood pressure drop. And one of the things that we are afraid is actually medical equipment dislodgement, but it only occurred in about 0.3% of the patients among all the mobility events or mobility sessions. The odds are actually higher if the children are not screened for delirium, or if we have screened them for delirium and they have positive screening, which means that they are having delirium. So this is what we need to focus on and try to screen all patients, pediatric patients, for delirium, because they have a higher odds or likely chance to have potential safety events during the early mobilization sessions. Rehab strategy number 4 to promote optimal functional recovery is to build trust and to have a supportive environment around the patient. Children after trauma always have heightened fear and anxiety. PTSD is a common psychiatric disorder in the pediatric traumatic events. For example, if they are involved in motor vehicle accident, and we know that motor vehicle accident is one of the major causes of pediatric trauma in Malaysia and also around the region, Southeast Asia. Therefore, early psychological intervention is very essential to support recovery. And the rehab interventions, to build trust and to build a supportive environment, we need to have the same team, same doctors, same nurses, same therapists as much as possible, so that those are all the familiar faces that the pediatric or the patients will see every day. Whenever we want to introduce the rehab interventions, we also will have to introduce different activities gradually, starting from the least difficult, least complex, least painful, to a more complicated movements or activities, so that again, this is really to build trust among the patients. Strategy number 5, always incorporate play and fun to get the cooperation from the patients. These are all these examples. We have garden in our ward, near our ward, in the building. This is showing a tricycle activity to reduce hamstring tightness rather than just doing the stretching in the gym. And another picture is showing standing and stretching exercises using wall games and trying to catch the lights that appear on the screen. There's also another one where we did aerobic exercises using the machine while we allow the patient to watch cartoons on her iPad. Although I know there's controversy regarding a lot of exposure to iPad, but nevertheless the patient is actually looking at watching cartoons and cooperate with the therapy regime. Another patient is using toy as part of the coordination, hand coordination therapy and movement. And you see how happy this boy is because the patient is on cast, bilateral lower limb, but with the team, we had a racing game in the ward to also at least they can cooperate with the rehabilitation program better. Strategy number 6, to incorporate short, integrated, combined activities during one session, because most pediatric patients have a very short attention span. They can only focus for about 30 minutes max before they start to wander and start to be very cranky. Therefore, the rehab strategies have to be short and engaging. It is better to incorporate multiple strategies in one session, trying to get multiple team members, for example, the therapist, physio, OT, speech. Sometimes the doctor will also come in one session and improve. For example, the first patient here, the first video shows improving balance, hand-eye coordination, and improve attention. And the other patient on the robotic equipment, we want to also improve his language comprehension and vision, because he has a vision. That boy is 1 year post-trauma and still undergoing rehabilitation with us. And this is just to showcase that we need to integrate all the activities in one setting, but also to ensure that the total rehab dose, which means that the total therapy time, must be sufficient enough to promote recovery. Strategy number 7 is to incorporate neuromodulation principles and neuromodulation rehab techniques in pediatric trauma that involves nervous system. For example, pediatric patients with traumatic brain injury or pediatric patients with spinal cord injury. These are the examples of firstly to use robotics, because robotics can improve the repetition and intensity of the movements, which is one of the principles to promote neuroplasticity. Another example to promote neuroplasticity is using constraint-induced movement therapy, which we actually constrain the good arm to allow the improvement of the weaker arm, and also to prevent non-use of the weaker arm, because the patients normally prefer to use the more, the stronger arm rather than trying to promote the usage of the weaker arm. Another example is to use the non-invasive brain stimulation. We have this in Malaysia, but for adult patients, we have not started this. We have not started this for the pediatric population yet, and hopefully we can somehow start the protocol soon for pediatric patients post-trauma that involves the nervous system. Strategy number 8, we have to incorporate family members throughout the continuum of care. This is very important. Efficient communication between the clinicians and the patient, and clinicians and the family or parents are important to improve the overall functional outcome. Strategy number 9, safe transition to home and society. I just want to bring this case where this patient had a traumatic brain injury, post-cranectomy, that we try to develop a 3D helmet to cover the defect so that he can return to school safely. We don't want, we cannot avoid him from, playing, with his friends, and therefore we create something to make sure that it is safe for the patient to return to school. Last but not least, strategy number 10, to prevent recurrent trauma, especially from motor vehicle accident, because it is one of the leading causes of pediatric trauma in Southeast Asia. We visited schools around the hospital that have high rates of MVA mortality and morbidity among their students, to create this awareness and to showcase to them what are the consequences and the long rehabilitation journey that they have to go through if they are involved in this kind of trauma. We also have an awareness program to public via social media to create this awareness annually. That is the end of my slide with the 10 strategies that I can share with you today, and I hope that all of you have can benefit from this lecture. Thank you so much.
Thank you, Prof. Mazlina, for the enlightening us on the rehabilitation work that you could do for children post-trauma. So before we go to the question and answer session, I would like to make some announcement. certificate of attendance. This will be available when you submitted to the post-webinar survey. And this link will be available immediately after this webinar. Please like us on YouTube and Facebook and follow us on our YouTube. Visit our website for more information. And as you know, ASPA is a non-profit organization. We like to seek for your help to donate and help us in our cause. Please go to our website and do some donation to help us in our cause. Last but not least, I would like to invite all of you to attend the SunCon ASPA 2025. This is the 24th Annual Conference of Society of Anaesthesiologists of Nepal, in collaboration with the 21st meeting of the Asian Society of Paediatric Anaesthesiologists from 4th to 5th April 2025 at Hyatt Regency Kathmandu, Nepal. This is a very important thing for all of us, because yearly we will then gather to meet all our colleagues and discuss about how we can move forward for anesthesia in children. And next year is in line with our 25th anniversary of ASPA. So hope to see you all there. Please go to the website and find more information on this. So now let all of us welcome all the speaker again. Dr. Rahanita Zahra, Dr. Kevin Ng Wishan, Dr. Anju Gupta, and Dr. Mazrina Mazlan. So let's go to the question. This is posed to Dr. Nita. Thank you for your excellent lecture, Dr. Nita. I want to ask you about using rocuronium on rapid sequence induction in pediatric patient. Are there any minimum age requirement for using these drugs, or can we use it in any age group?
Okay. Thank you, Professor Ina. Actually, for rocuronium is the muscle relaxant that have a safety profile for pediatric patients, since it's already approved from FDA. And there's no minimum requirement for pediatric patient, but we do have to adjust the dose. We know that in neonates, we have to give a lower dose for rocuronium because you know that there is immaturity of the enzymatic liver enzyme in pediatric, hepatic enzyme in neonates. And also you can give the higher dose for infants, because you know the volume distribution is larger in pediatric than adults. So start from the dose 0.6 to 1.2 micro per kg for pediatric patient. It will give time 60 seconds for the maximum blocking muscle pediatric patient. But you have to pay attention for RSI. Usually, if we found a patient with the difficult airway in pediatric, we have to remember that once you give medication, you have to you can go back and you have to mitigate the plan. And that's why I already told in my lecture that every time we met the pediatric with difficult airway, we have to communicate with the surgeons. In my hospital, we don't do the tracheostomy by the anesthesiologist, so we have to prepare and we have to communicate to the surgeon before we start. That's from me, Dr. Ina.
Thank you, Nita. Yeah, I do agree that rocuronium in children, there's no age limit now. More information will come out soon, as I think we have just concluded the multi-center trial on rocuronium in neonate to the 2 years old. And we know because above 2 years old, the kidney react differently. It's immature, so the metabolism and the excretion of the drugs is different. But more data has been collected from this study, and it should be more information will be available next year. But I do agree with I think what you've just mentioned, Dr. Nita. So next question is to Dr. Anju. Thank you, Dr. Anju, for the presentation. For pediatric trauma, when we encounter patient in ED setting, will you provide regional anesthesia, for example, fractures in ED? And will you perform RA in awake pediatric patient? And if you perform awake, what is your strategy?
Okay, thank you, Dr. Ina, for the question. Actually, in pediatric patients, as a rule, regional anesthesia is advocated to be done under general anesthesia or at least in very deep sedation, because it is said that it is felt that the safety of a child, immobile child who is not moving during the procedure, that outweighs the potential for any nerve injury or any pain or paresthesia which may not occur or which may not be reported by the child. Even if the child is awake, there is a very less chance that the child will communicate any pain or paresthesia which is occurring. So even large registry like PRAN registry, it has which evaluated around 1 lakh children. They in fact mentioned that the chances of complication was 7 times more when the blocks were performed awake as compared to when the blocks were performed in a sedated or deeply sedated or general anesthesia, under general anesthesia. So even the ASRA-ISRA combined joint guidelines, they came out with the guidelines and they said that as a rule, it is a standard of care that the block should be performed in a sedated or general under general anesthesia. So that is very well advocated in children. So as a general rule, it should be performed in a awake, in a sedated or under deep sedation or general anesthesia. However, that being said, there may be conditions where we would like to keep the child awake. And there are reports, as I also mentioned in my presentation, there may be some very high risk children where the general anesthesia, the risk may be prohibitive. In those cases where it is selectively indicated, we may go for awake regional anesthesia also. But in those cases also, we should make the child comfortable with mild sedation, which is not impacting their respiration or leading to any harm, like dexmedetomidine. I have in my practice, I have also done some cases of regional anesthesia in a sedated child, mildly sedated child, where the child was comfortable and the regional anesthesia was done with prior preparation, like application of AMLA. In a child, I did a CSE. It was a osteogenesis imperfecta severe type, and the airway was very difficult, and in general, the child had very high risk. So what I did was I preoperatively applied a EMBLA over the lumbar site. Then I then I located the space by using ultrasound, and then I sedated the child mildly by using dexmedetomidine, and then I had counseled also the child very well, and then I performed this regional anesthesia, and the case was done with dexmedetomidine sedation only. So these kind of also in literature there are studies where they have done the procedure awake with using mild sedation, mild TCI, mild 1 mic per ml type of sedation. So that is also possible. In ED, not many reports are there for children. So I'm not very aware about the ED setup where the blocks for adults are performed in a on arrival blocks are generally performed for adults. But there is not much literature about children in this aspect. So if anybody else has his experience to share in ED, they are welcome to add.
I don't know. Anyone else had experience in ED? What about in Malaysia? I don't think we go to ED to do blocks, right, Kevin? What about in Indonesia, Nita? Do we do? Dr. Nita.
Yeah, in Indonesia, sometimes but actually we have one anesthesiologist in our ED, and he sometimes if the patient needs to do block, we can come to the emergency department or the ED to do for the severe pain of patient, Dr. Pravena.
Yeah, I do believe it can be done, right, Kevin? And I think using dexmedetomidine, is it IV that you use, and Dr. Anju?
Yes, Dr. Ina. We give IV bolus over 10 minutes and then followed by an infusion. Generally, it is given in a low dose, like a bolus dose of 0.5 mic per kg per minute, and then followed by infusion of 0.3 mics per kg per hour. So
Do you think that's enough for procedural, just using IV Dex? Do you need to add on ketamine on top of that?
actually, it varies a lot in pediatric patient. Every child is different. Some patient may like to be completely awake. There was one child in who presented to me for a foot surgery, and he completely refused to go for general anesthesia. He told me straight away that he doesn't want general anesthesia, and you can do any kind of injection. So I gave femorosciatic block, and he
Wow.
was very happy with the block, and he stayed awake, and he just was happy with the mobile phone. And so these kind of cases are also there, so we should not assume, and we should always discuss it out with the surgeon and the patient, what is his priorities and preferences. But yeah, regarding for procedural block, we it may be, if the child is moving, that can be detrimental, that can lead to nerve injuries. So it is better that if the child is moving, and if the child is not cooperative, or you anticipate that the child will move, then you can give a propofol bolus, or short term infusion. But once the block sets in and the child realizes that he is comfortable, there will generally be no need of further sedation. We can just hand over a mobile phone, or a smart any cartoon film, whichever the child prefers, that can be used. I have used that. So I am very fond of spinal anesthesia for children. I have been practicing that. So what I do for that spinal anesthesia, I generally discuss it out with the child, and ask his preferences. If the child likes to be sedated, they tell it to me that they want sedation, they want to sleep. Then I give a sedation. Otherwise, we just hand over a smartphone, and the procedure is done. And then if you have given a topical anesthesia to the site, like using EMLA, and if the child is cooperative, it can even be done without any sedation. But only thing is the child should be comprehending what you are going to do, and the child should be cooperative. But in general, even if you go for deep sedation, there is no problem at all in that also.
Okay, thank you, Anju. Now, that was a question from Dr. Pei Huangu. Dr. Pei Huangu also sent another question to Dr. Kevin. Thank you so much for your informative presentation. I would like to know, in traumatic brain injury of a child more than 1 year old, should we start tranexamic acid within 3 hours of injury and followed by infusion, or just the stat loading dose? And in what criteria should we activate massive transfusion protocol?
Yeah, thank you for the question. Now, it's very difficult to say. First question, Crash 3 says we should Crash says that we should TXA followed by the infusion for traumatic brain. Generally that's the thing that we would do for adults. But in children, there is almost zero evidence to suggest that. And what I would do would be bolus dose, do the VET, guide from VET. That would be the safest way to give. The reason why I'm erring a bit on the safer side, because you do note that children, even though they approach adult levels of most of the coagulation profiles, they tend to be slightly pro-thrombotic compared to adults. That's what a lot of the studies have shown. So you do have to be careful that you don't end up with more complications. But if they are hyperfibrinolytic, then yes, you can consider that. There are actually quite a lot of different views of looking at it. I am a bit more conservative with the tranexamic acid in children per se, because I've had one experience with the thrombotic event after a prolonged infusion. So I'm a bit more conservative on it. But between the two, I would say use a VET to guide you. That would be the safest way. It's objective. It will allow you to be sure of what you are doing and targeted. Now, with regards to massive transfusion protocol, as mentioned in my in the slides, it's not very well established. Again, not very well established in children. So if you ask me when would I consider the massive transfusion protocol, 20 mils per kilo of fluids, I've given my first 10, 20 mils per kilo of blood and it's still bleeding, it's still ongoing, I would trigger a massive transfusion protocol at the 20-20-10. So 20 mils plasma, 20 mils packed cell, 10 mils of platelet, and then ask for that to be repeated as needed until we have stabilized the patient.
Okay, thank you, Dr. Kevin. One question for Dr. Mazlina. What do you think is the biggest challenge to start rehab in children post-trauma?
Okay. Again, I feel that the biggest challenge is that we are not there from the start. So we need to get their trust early. We have to be, this is the movement in the rehab medicine fraternity as well. It's actually to have the critical care rehab team where we are there in the ICU itself. And other than that, it's really getting the team that is well versed in managing patients and to start, because people are a bit afraid to start all the rehab the strategies and that very early when they are still with all the wires and tubes in ICU and also in the acute ward. So that I feel is the biggest challenge. Other than that, we do after it's slightly later when they're quite okay, we have a good team to actually support the rehabilitation, because we do follow them up for a long time. Like I said just now, we do have patients, especially after like trauma, like burn or traumatic brain injury, spinal cord injury. We follow them throughout the years because they will have all those different challenges and different problems, medical issues throughout the years actually. And like I said, especially the one that's comprehensive and complex that involve bladder, bowel, nervous system, cognitive. We see, we cannot assume that the patient, regardless of age, that they'll be okay, because the PTSD and those that occur, the psychological consequences after the trauma, we can only see probably after years, from the trauma event itself. So we do follow them up until like for a very long time. But we want to start early. I think that's the main challenge.
So I think maybe there's also a role of regional anesthesia to start early during the rehab processes when they're still acutely ill, right, in ICU and whatnot, even if they're not sedated, so that you can start your rehab process quite early. So yeah, we should work more multidisciplinary to treat our post-traumatic patient. We look forward to that work, Prof. Mazlina. So before I end, there's another one question I think is quite interesting, although it's like not directly related to trauma, but because we talk about this drug, we have our expert here, Dr. Vivian, on it. This is from Dr. Alma. Can we give dexmedetomidine in neonates, and how long can we safely maintain the infusion? I think because Vivian is the expert, we can share her expert's opinion here.
No, I won't say I'm an expert, but we do use dexmedetomidine in neonate. We see it used in NICU, PICU, and also for sedation, like when we have to do neonate imaging or intervention. That will be my first choice. So I usually use this as the foundation of sedation, and I add whatever is necessary. Say for pain, I have to add analgesia, or if I have to further deepen anesthesia or sedation, I might add just like hydrating dose of propofol, etc. So we do use dexmedetomidine in neonate. Of course, we always try to be more careful with neonate because they have less margin of safety and they are more susceptible to apnea. And also, how long we can use, I think we see it used in ICU for a long time, but when you tend to use it for prolonged period, you use it as a small dose, as the background sedation, and then you have to do your analgesia or other things on top. So that means if you use it for a long time, usually we use it at a lowish dose, like 0.2 or 0.3 mic per kilo per hour for neonate and infant.
Okay, thank you, Dr. Vivian, for that elaboration on dexmedetomidine. So I think it's already 10 to 7. We've got it's Sunday. So let us end our discussion here. We really hope we should give a round of applause to all our speakers who shared their experience in this meeting. We hope this session has highlighted the importance of a comprehensive team-based approach in pediatric trauma care, an approach that combines technical excellence with compassionate, patient-centered care. And holistic management, I just like to emphasize again, the holistic management of pediatric trauma patient, multidisciplinary is paramount. So thank you for joining us today. And we look forward to you in joining us at next year's ASPA-FLEX webinar series. Again, please register for our ASPA 2025 in Nepal. Last but not least, we'd like to wish all of you, to those who are celebrating, a Merry Christmas, and to all a blessed New Year ahead. Once again, thank you very much for being with us today. Bye.
Bye. Bye and happy